So I am so happy to again share with you these slides. Okay. And what we're going to discuss is just the part 3 of the MSK Ultrasound study of the ankle and foot. But before we begin, let us just bow our heads for a short prayer. Let us pray. Loving Father in heaven, thank you so much, oh God, for you have always been so faithful to us. You have provided us, oh God, everything that we need, and most especially for preserving our lives and sparing us, oh God, from COVID, and for always providing us the means that we can use for our study, and at the same time, Lord, to support our family and to help our patients. Lord, as we study a subject that is very challenging this evening, we would like, Lord, to ask for your guidance, for your Holy Spirit to please teach us to share this, and it may be understandable for everyone. Thank you, oh God, for your grace. In Jesus' name we pray. Amen. So good evening. Can you hear me? Is the audio good?
Loud and clear.
Yes,
Okay.
Doc.
Okay, thank you. Thank you, Joe. Thank you, Pash. Okay, so this is the part 3 of the MSK Ultrasound study of the ankle and foot, and we will just focus on the forefoot. Okay, again, as I always begin, I would like to read this book from the book of Isaiah 40:29 to 31. It says, God gives power to the weak, and to those who have no might, he increases strength. Even the youth shall faint and be weary, and the young men shall utterly fall. But those who wait on the Lord shall renew their strength. They shall mount up with wings as eagles. They shall run and not faint. So this is still a very beautiful promise that if we wait on the Lord, he will be able to renew our strength. And sometimes we run out of patience and we can no longer wait, but we still have to wait because the blessings comes when we wait. So we will begin our study on the Lisfranc ligaments. And we know that Lisfranc is a part of the foot where it divides between the tarsal and the metatarsal area. And so in this slide, what we're looking at are what we call the Lisfranc ligament complex. So this is really a very complex structures. And as you can see here in this slide, you can see the plantar view on the left and the dorsal view on the right. So as you can see, the plantar ligament complex is made up of the plantar oblique component. So we will go over the details later on, but it's enough for us to know that this is actually referring to the cuneiform 1 attached to the metatarsal 2. So C1, M2. And then the rest are made up of the plantar intertarsal ligaments. Then we have the plantar tarsometatarsal ligaments, which are made up of 6 to 7 ligaments. And we have the plantar intermetatarsal ligaments, which are made up of 3 ligaments. And if you will notice, it attaches only the 2nd, 3rd, 4th, and 5th. And so there is no attachment between the 1 and the 2. So you just have to take note of this because this is a very important part which we will use this later on in our discussion, especially in the diagnosis of Lisfranc ligament injuries. Now on the other side, we have the dorsal view. And here what you will notice is that it's just a mirror image of what we see in the plantar view with 7 also dorsal tarsometatarsal ligaments, 1, 2, 3, 4, 5, 6, 7. And then we have the mirror image of the dorsal intermetatarsal ligaments right here. And again, there's no attachment between M1 and M2, or metatarsal 1, metatarsal 2, and then of course the dorsal intermetatarsal ligaments. So that's how it is arranged. And then of course here in another diagram or illustration, you can see here how these interosseous intertarsal ligaments are attached, and of course the interosseous tarsometatarsal ligaments. He will show the details to you in the next slides that we're going to study. But so this is just the overview of the ligaments that forms the Lisfranc area, or what we call the tarsometatarsal joints. So the ligament structures of Lisfranc are made up of 7 dorsal ligaments. Okay, as you can see it here. And this is arranged in such a way that there is an attachment between C1 and M1. Then we have the C1 and M2. This is the most important attachment. Then we have the C2, M2, C3, M2, and then C3, M3, then cuboid, M4, cuboid, M5. And as you can see here, why, you might ask yourself, why is it that most of the ligaments are going to the direction of M2? Because actually the M2 here serves as the keystone. This is the most important of all the bones in the forefoot. This is the most important here, M2. And so if there is something wrong in the ligament attachment right here, this will sort of cause instability in all of this area. So this is like the keystone. It's almost like the carpal bones in the hand, or the scaphoid in the more proximal part. Then of course, we have the 7th plantar Lisfranc ligament also. Of course, it also matches this area on the side. And then I just highlight this very important structure, the C1, M2, and of course the C1, M3 on the plantar side, because this is actually the one that is being referred to as the most important plantar Lisfranc ligament. These 2 ligaments right here, C1, M2, C1, M3. And then of course we have the 3 Lisfranc ligaments, or the interosseous ligaments, which is actually mostly represented by C1 and M2 here. So there are different studies which says that there could be more than 2, 3, or 4 bundles that made of the fibers of the Lisfranc ligament, or the interosseous ligament, and it depends upon the thickness, the width, and of course the angulation. And then of course we have the C1M, or the cuneiform metatarsal plantar ligament, or sometimes we call it, depending on how it is arranged, we call it the plantar oblique ligament that forms also the Lisfranc ligament that forms the Lisfranc joints, which are arranged in such a way that this also helps in the stabilization of the Lisfranc structure, or the Lisfranc ligament. So here we narrow down to the most important part of these ligaments, which are in the dorsal view, the C1 and M2. So this is a very important structure. Now this is important because, as you can see, there's no attachment between M1 and M2. So it sort of compensates that there is a ligament which is present attaching C1 and M2 instead of directly making M1 and M2. In fact, from of course people believes about evolution, but this one is however made in such a way that there is a separation here in the past that allows the feet to actually hold itself on objects because of this arrangement here, where there is no ligament here in between. Of course, on the plantar side, you will also notice the same arrangement. So C1 going to M2, and then C1 going to M3. So in other words, this attachment here is the one that is compensating for the absence of M1 and M2 attachment right here. But at the same time, in order to stabilize further and to make actually some kind of an arch, the C1 ligament is also attached to M3, and then this kind of arrangement will facilitate sort of holding an object much like the hand, where there is an arching of that particular area. So, we mentioned earlier that of all the bones that forms the Lisfranc ligament complex, the most important is, of course, the M2. And this is the keystone in this particular area. And we will try to see a lot more about that in the next slides. Okay, so here, if you will notice a gross picture of these ligaments, they are so small you can hardly differentiate between one from the other because of the intricate arrangement of these ligaments. So if, for instance, you try to dissect them, you will see a lot of this comes like an overlapping structures that you cannot distinguish one from the other. So what is important is to identify how are they attached and what is the direction of their attachment, and of course the angulation where they are attached. That really makes a lot of difference when we study this particular area. So it's so complex to think about how they are arranged. And in the plantar side, same arrangement. So it's also a lot of ligament. Of course, there are still small parts that you can see that forms the attachment of all this structure, but by and large, you will notice that the bigger ones, which what we are trying to emphasize, is that you can actually highlight the structure here. Sorry for that. So let's see, for example, here the C1, M3, and of course the C1, M2, which is a very, very small ligament, are the ones that really attaches very clearly in that area. And so you can see it's also here, it's being highlighted how they are really attached. So it's a matter of you seeing it if you know it. So it's like if you don't know it, you will not be able to see it. So it's just like a plain structure right there. And sometimes it's very hard to understand. Okay, and then of course, another picture of how intricate this arrangement is. So C1, M2, C1, M3. Okay, and then of course, there are other connections between other cuneiforms. And you can see here that it's not only attached directly to the metatarsal, but between each other, the cuneiform ligaments that makes the foot really in a more stabilized condition. So the dorsal ligaments of the Lisfranc joint complex is made of, as we have mentioned earlier, the intermetatarsal between the three ligaments here, except for the M1, M2. And then, of course, we have the dorsal intertarsal, which connects all of these four tarsal joints right here, the three cuneiforms and cuboid, and then how the dorsal ligaments of the Lisfranc are connected to each other. Okay. Now, with this Lisfranc joint complex, we have also articular capsules. In other words, the capsules which form the joint itself. And there are basically three articular capsules. And what they found out is these capsules do not communicate to each other. In other words, if there is a swelling of that part, if we talk about rheumatology, it doesn't go to the other side, or it doesn't necessarily move to the other joints because they don't connect. There is no communication that you found between them. So this includes all the articulations between the tarsal bones, with the three cuneiforms and the cuboid, and of course the five metatarsals. So on the medial side, we have C1 and M1. That's the first articulation. So we call it the medial articular capsule. The central, there are many. So we have C2 and then M2 right here. Then we have C3 and M3. And then, of course, we have C1 and C2 right here. Then we have C2 and C3 right here. We have M2 to M3. We have C3 to M2 and C3 to M4 over there. So the expanse of central articular capsules are made up of several joints. If you count them all, it's about 7. So 1, 2, 3, 4, 5, 6, 7 articular capsules. And then, of course, we have the lateral, which is coming from the cuboid, and we know that it's right here located, and then it articulates with M4 and M5, and then of course we have M4 and N5 articulations between the two metatarsals on the lateral side, and that forms the lateral articular capsule. So those are the anatomy that we see in these joints. Okay, so the Lisfranc ligament proper is actually made up of a thick oblique ligament coming from M2 and C1. And then, of course, we have already mentioned that. So if this is your C1 and this is your C2 here, so it's just this area here. So C1 and M2, that's the Lisfranc ligament proper, or what they call the interosseous ligament, or some writers would say the Lisfranc interosseous ligament, or the Lisfranc ligament complex. When they include already the C1 to C3, then they call it the plantar oblique component. Okay, so that's C1 to M3 right here. C1 to M3. So as we have mentioned earlier, there is no M1 and M2. So instead, it is compensated by C1 to M2 and C1 to M3. So the stability of this particular area could be explained by the presence, or by the presence of the ligament, which forms C1 M2 and C1 M3, because there is no M1 and M2. And in addition to that, the amputation of Lisfranc, okay, so right here, if there's an amputation right here, okay, will actually cause instability of the Lisfranc joint. In other words, since you already remove all these parts here, so there's no way wherein this ligament could be attached. So as part of this arrangement, there are also some authors which divide these parts into 3 parts, into the medial column, the axial column, and of course the lateral column. So the medial column refers to C1 and M1, which is the most stable. So this is the one. You can see here it's a very, should I say, the arrangement is closely packed in this area. And then of course M2 and M3 is what they called the axial cuneiform, articulating with C2 and C3 over here, and of course the C4, M4, and the M5 with a cuboid, which forms the lateral column. So it's just a different way of looking at this particular anatomy. So these are other details of this particular ligament with the bundles. As we mentioned earlier, studies have shown that there could be 1 bundle, 2 bundles, or 3 bundles. Majority of them would say 2 and 3. It's a mix of 2 and 3. It really doesn't matter. But what is important here is that for as long as this area here is stabilized with this particular attachment of C1 and M2, then that is good for this particular structure, stabilizing the Lisfranc ligament. Now, if you look at the ultrasound, how would that look like? So what you need to do is to actually put your probe this way, right on top of cuneiform. Okay, the reference would be the most prominent area at the dorsal foot, with the foot partially plantar flexed. And so if you put your foot like this, and you put it right on top, which is actually located between the C1 and passing through M2 and M3, then you can see the ligament attaching right here. So this is an image that they see where the ligament is actually intact, attaching your C1 and of course your M2. So it's really very visible, because with this arrangement right here, and you put your probe in some kind of an oblique position just to follow the length of the ligament right here, you'll be able to see and appreciate the ligament attachment here. So you can actually view them and just try to toggle and do some heel toeing in order to visualize that area on the foot, because a lot of times that could be very painful, and maybe some of your patients will be complaining of that particular area. Of course, from the perspective of the ligament, that is what you see, but there is also a very small nerve on that area, but we will not discuss it right here. Okay, so the classification of this front ligament and C1, M2, M3 plantar ligament with all these bundles that we see are classified depending on the number of ligaments, the number of bundles, and of course, other criteria in terms of whatever they see to be connecting between the least front ligament C1 and C2, C1 and M2, I should say. So this is the most common, which is actually the type 1A, and of course, the other arrangements are not so common. So this is the typical one, and you can see here the ligament between C1 and M2 that is made up of just one bundle. So that is really the one that is common. Of course, they can have more than one, like 2, 3 bundles that you can see. Now this particular image, if you do an initial X-ray, is a very important view, especially this space between M1 and M2. Now, why is this important? Because some of your patients might actually complain of pain over here. And later on, I will let you know how you can actually measure this distance and deduce from this if there is a torn ligament or a torn bone or a chip bone. And if there is widening of this space, then that means there is a torn ligament, not necessarily between M1 and M2 because there is no ligament there, but it refers to the C1 and the M2, okay? So this is a very important picture. And of course, this is another view of the MRI here. So this is just confirming if there's any presence of an extra bone right here, which is confirmed by the presence of this structure in between. If you view it by MRI, of course, you don't quite see it on the X-ray. Okay, so the disruption of this ligament, in other words, referring to C1, M2, M3, or the plantar oblique ligament, is the single best predictor of instability. So anything that disrupts this area, and when we say disrupting this area, it would refer to the distance between M1 and M2, is the best predictor of instability in this area. So in what sports do you see this? Basketball, football, gymnastics, no? Especially when they land on inappropriately on the foot, with the forefoot hitting the ground first. So the axial longitudinal force to the foot in a plantar flex and slightly rotated position, you will feel a pop at the time of injury, and then of course the patient will feel foot pain during weight bearing. Now, most of the time, we don't see any problem. So X-ray will not show anything because sometimes we don't really know what to look for. We just look for fractures, but there is no fracture. So the absence of fracture doesn't mean the patient is normal. So how do we actually diagnose this kind of problem? And surprisingly, if there is a delay in the diagnosis, it could cause midfoot instability and some post-traumatic degenerative arthritis. That's why it's very important to know how to really diagnose this problem. But before we go over that, I just would like to show you here other variations that you can see from the foot between the second interosseous coniometatarsal ligament, in other words, C1 and M2. So these are variations, and also the variations between C1 and M3, the third interosseous coniometatarsal ligament. So these are just giving us idea that there's a lot of variations that we can see here. Now, so the other thing that is very interesting to consider here is the presence of what they call the lateral Lisfranc ligament. Not everybody agrees to the presence of this ligament, okay? But diagrammatically, if you'll notice, it's just found right here below. So it spans from M1 up to M4. So almost like this. Okay, so you can see it here. Now, it's not present in all patients, okay? But this could be found to be adding some stability in the plantar portion of the foot. Now, it is just underneath your peroneus longus tendon. As you can see, it wraps around your foot, okay, from lateral to medial. So if you remove that, you can actually see this better. And you will notice here the expanse of this particular structure at the plantar foot, okay, when the peroneus longus tendon is removed. So it originates from M5 and inserts into the M2 lateral plantar aspect. Okay, so the Lisfranc ligament complex injury, so it runs obliquely between the C1 and the base of C2. So C1 to C2. So this area is very important. And of course, the weakest part is the dorsal oblique. And then, of course, the strongest is the C1M2. This is the one that really stabilizes. And of course, we have the C1M2M3 plantar ligament, which is the second strongest. And then we also have the plantar oblique, which consists of a strong superficial band inserting up to the base of M3 and a less substantial deep band that inserts at the base of M2. So we already described this in the previous slides. So this is how to make the diagnosis. So if we do an X-ray and we don't quite see any fracture, but the patient is pointing at this particular area and trying to insist that, doctor, that area is painful. And you will say, but there's no fracture. So you're okay. What we could do actually is to measure the distance between M1 and M2 here. Did you see this? And if there is 4 millimeters widening of this area, then that means there is a disruption of that particular ligament of C1 and M2. Sometimes there could be an avulsion fracture, a very small bone here that sometimes you could hardly see. But if you know exactly what to look for, you might be able to actually see what's wrong with the patient. It is a bony fragment in the first intermetatarsal interval. So it's a very small bone. You might not really be able to see it, but ultrasound can actually help you find out what is happening here. But of course, this X-ray is important in the beginning because we will be able to measure the distance with it. But you have to do an X-ray, weight-bearing AP X-ray. So there has to be weight on it in order to make sure that there is a widening effect when you put weight on that foot that is involved. So that is how we can diagnose this particular injury involving the Lisfranc, C1M2. So in the ultrasound, this is from the study of Reyes, 2018. And C1M2 here, this is the image of an intact C1M2 ligament. And on the right side, you can see here the C1M2 sprain with the hypoechoic swelling of this ligament right here, as you can see it. And then you can see here a disruption, okay, of the C1M2, which means that there is really an injury of that Lisfranc ligament. So there is widening And there is also this particular lesion over here that says that this whole thing here is actually injured right there. So this is how we could diagnose it by means of ultrasound on the plantar foot. Of course, we can view it more at the plantar side because that's where it is usually located with the ligament, although we can also check it on the dorsal side in order to just counter check whether there's a widening of that area, and then we can also take a measurement. Of course, this is a midfoot pain of a 28-year-old rugby player, and as you can see here, there is a complete rupture diagnosed by MRI of the interosseous ligament. Okay, there is widening here, and of course, there is detected deformity of the bone, as you can see it. And of course, this is a full thickness tear of the C1 and M3 ligament. If you would like to look at it from an MRI. And of course, the X-ray here, it shows a kind of dislocation of this M1 from the C1. And of course, widening of the C1-M2 side-to-side difference. And if you can see it, this is already an indication for surgery. So for those of you who are doing surgery, then this could really help you a lot. And you can actually let the patient understand that there is really a reason for him to do some procedures right there. Now, these are different patterns of Lisfranc injuries. So if you look at the first one, this is the most common, where there is a disruption between the C1 and the M1. Okay, so that is the traditional one. Now, in the medial column dislocation, there is a disruption between the C1 and the M2. So as you can see here, there is a cleft right here, C1, M2. Then this one is a more complex one. So aside from C1 and M1, there is a C1 and M2 disruption as well. So those are very important thing that we can look at when we do an X-ray. So by the X-ray, you can easily identify right that there is really something wrong, because obviously there is widening that you can see here. There's widening, there's widening. Of course, this one, aside from the widening, there's also a dislocation that's occurring in the joints, in the bones. Now, there are other ways of classifying this. This one is from Meyerson classification of Lisfranc injuries, where there is not only disruption of the whole Lisfranc in type 1, or it could just be confined to C1 and M1, or there is a C1 and M1 and the entire Lisfranc, but at the same time, there is separation of M1 and M2, with the rest of the M2 moving to the lateral side. So those are the different classification of Lisfranc. Now let's go to your foot ligaments. Now, as you can see, there's also an interesting structure here in the ligaments of the foot. And this is highlighting the big toe. So the big toe is made up of two phalanges, the proximal and the distal phalanx, and of course the metatarsal bone right here. But at the same time, at the plantar area, there is a sesamoid bone, the medial and the lateral, or the lateral, should I say, or the tibial and the fibular sesamoid bone. And the sesamoid bone doesn't just exist independently, but there is an attaching ligament that stabilizes them. So for instance, between these two, we have your intersesamoid ligament, or the ISL. Then we have your tibial phalangosesamoid ligament on the side of the tibia here. And then posteriorly, there is a flexor hallucis brevis tendon. Then on the lateral side, or the fibular side, we have the fibular phalangosesamoid ligament. And then, of course, the lateral collateral ligament right here, you can see here. And then, of course, posteriorly, we have part of the flexor hallucis brevis tendon. So, in other words, what we're saying is it is stabilized by the ligaments. It doesn't just exist there by itself. Now, in an injury described as a turf toe, where there is a dorsiflexion or hyperextension injury of the foot or the big toe, Okay, so what happened here is this, the capsule ligamentous complex of the MTP joint is the one that is injured. So usually if there is more than 3 millimeter distance from the sesamoids, which means this one or this one, to the proximal phalanx, which is this one. So we measure this, more than 3 millimeter distance. Then there is a 3/4 ligaments injury of the plantar plate. Now let's try to look where exactly is that plantar plate. Okay, so right here. Okay, so again, this is just the same representation, except that this is a cross-sectional area, or the cross-sectional representation or diagram of the structure we have seen a while ago. But at the same time, of course, these are the other details. We can see here the plantar foot ligaments. Okay, that is the plantar ligament of the MTP joint. This is the deep transverse metatarsal ligaments. This is the plantar ligaments. This is the plantar ligaments. And this is the deep transverse metatarsal ligaments on the plantar side. Okay, so those are the pictures that we see. Now we're looking at, and this one also is the medial collateral ligament. This is the deep transverse metatarsal ligament. Of course, this is the medial collateral ligament right here, as you can see it. But the plantar plate, which we are looking at, is this one. Okay, so the plantar plate wraps around the flexor digitorum longus and brevis on the plantar side, and this kind of support this structure in such a way that it cushions the load when we put weight on it. Okay, over the forefoot. And this is also important in doing the windlass mechanism of the foot, where we transition from heel strike to foot flat and to heel off position. Now, there is a problem, any problem I should say, in the plantar plate will also affect the loading mechanism of the plantar foot, as shown here. So in other words, when there is a disruption of the ligaments that is attached, shown in the previous slide, then the plantar plate also will be affected. So it's also very important to see, and I have to go back to the previous slide again, just for you to see here. Okay, so as you can see here, this is the structure of the ligament, and just in the inner side is the plantar plate. Or should I say is the plantar plate right here. So any injury, just as in the case of a turf toe, will injure the plantar plate, especially when there is an excessive distance from the sesamoids to the proximal phalanx. So that is what happened here. And of course, in the ultrasound, this is what we see. Okay, so that is the plantar ligaments. And then of course, this is the plantar plate right here. Okay, the black part. And then of course, the plantar plate is this one right here. Okay, this is actually a very thin area right there, just beneath the plantar ligament, and of course, the muscle that is right on top of that. So this is, let's say, your bone. This is M2, M3, and M4, and the plantar plate is just right here. Now, we can see that because as we position your probe this way, this is the picture that we can see. Okay, so this is the long axis view, and then of course this is the short axis view in this presentation. So this is the plantar plate right here. Okay, this is the plantar plate. 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 Okay, so in the turf toe, the plantar plate is destroyed. Now, there are other ligaments that you can find here in this particular area. We have the accessory collateral ligaments and the proper collateral ligaments. So ACL, accessory, and then proper, or the PCL. It comes at the metatarsal tubercle, okay? And the PCL, of course, attaches to the plantar base of the proximal phalanx, and ACL is attached to the plantar plate. So this one is plantar plate attachment. This one is the brace of the proximal phalanx. So if there is any injury of the plantar plate, it could cause instability of metatarsophalangeal joint. But if you section the ligaments, it doesn't necessarily cause instability. So we need to remember that the plantar plate is the one that causes instability in this case, and not the ligaments. Okay? Now, let's go to the plantar fascia. So I included the plantar fascia in this lecture and not on the previous lecture because there's a lot of information that we can see here, especially in their attachment. So let's say the one that we normally see in the plantar fascia is just the main part, which is the central. The lateral and medial, we hardly see this unless we actually really like to look at it. And the central part is usually the thicker part. And of course, distally, it's thin. But of the three, this is actually the thickest among the three. So here, for example, this is the central part. This is the medial part. This is the lateral part. So as you can see here, the lateral part is very thin. The medial part is the one that we commonly see. And the medial part here only starts at the middle portion of the midfoot over here. Okay? So that is how this plantar fascia is arranged. So the attachment is interesting because there's where the most of the pain really comes from. And any pain that originates at the calcaneal area, we would always tell them to be coming from the plantar fascia, or if we cannot really find it, sometimes we say there could be some spurs that's forming. And to some people, sometimes you see, oh, there's a nerve, the Baxter's nerves is compressed on the area. And so what exactly do we see when we actually image the plantar fascia? So again, imagine this is the central band here. So it's the big, this is the one that is normally seen. This one is the one that we do not quite see a lot of times, and the medial band is over here. So when we look at these bundles and learn that this has a very important role in terms of weight bearing. So the most commonly stressed part, if that is the correct word to use, is usually where it originates at the calcaneal area right here. And it is very useful to use an ultrasound because that's the most available and the most practical way of looking at it. Sometimes the X-ray will not show you anything except for the fact that there could be some changes in the densities, but it doesn't give you a lot of information. So when we look at this particular area, interestingly, some would always think that this could be connected also with the Achilles tendon. In fact, the collagen bundle, okay, that goes all the way to the plantar fascia is common with the one that we see in the Achilles tendon. Of course, there are a lot of studies which confirms that, but we will not go through that in a more detailed way. But more importantly is the fact that when we actually do and diagnose plantar fasciitis or look at the plantar fascia for that matter, there are different ways of measuring that. So now this study that is made by Granado tries to look at the thickness of the plantar fascia in different positions. In other words, at neutral, then at partial dorsiflex position, and then of course the extreme dorsiflex position, and then trying to compare what happens with the thickness. Now, normally there's not much difference that they have seen, but what they saw is that the average thickness of the plantar fascia is ranging from about 3 millimeters, and usually the site of measurement should be right here. Of course, sometimes you measure it here, or sometimes you measure it right here, but this is where you should actually measure it, right at the tip of the attachment of the plantar fascia on the calcaneum. So that is 3 millimeters. And anything that is more than 4 millimeter thickness is consistent with plantar fasciitis. Now, other than that, we should, if your ultrasound can do it, we should also measure the power Doppler and tries to see the increased vascularity. And then it has to have indistinct margins and hypoechogenicity. You don't quite see the margins anymore because it's swollen and there is a lot of vascularity that you can see. And then of course, you can also do a simultaneous stretching of the Achilles tendon and plantar fascia more than 4 weeks, which is actually an excellent way to assess heel pain due to plantar fasciitis. So those are important information that we can take note when we do an ultrasound. Now, this one is another way of measuring by ultrasound the lateral band, which we don't quite measure all the time. So we move the probe to the lateral side and tries to see how the plantar band of the plantar fascia really looks like. So plantar fasciitis or plantar fasciopathy, as some would call it, is a degenerative process that is more dominant than it is inflammatory. So the cause is a mechanical overload and excessive use, causing micro tears, which initiates the inflammatory process. So when we walk, the load on the plantar fascia exceeds its capacity, causing degenerative change. So which part? Its proximal third of the central bundle is classically involved, but it could also involve the distal plantar fascia, especially in a recalcitrant heel pain. So there are 2 areas that you might want to see, the proximal and the distal side, because those are 2 areas that could give you some information about what is happening. And then, of course, as I've mentioned, this is the best part to measure it, okay? And if it is more than 4 millimeters, then that is indicative of plantar fasciitis. This is also another image of a shear wave elastography, okay, just for you to view if there is any inflammation that is happening or early sign of inflammation that is happening in the plantar fascia. So you can use power Doppler, more than 4 millimeters, or there is a contrast enhanced. In contrast enhanced ultrasound, what they use is they inject a dye and they also view the image through that dye that is injected, and of course there is a muscular volume that could be detected. And of course, if you have other features in the ultrasound with microvascular imaging or MVI, then you can also use that. And those that will give you an information that is even earlier than any pathology that you can see. For example, an athlete that you would like to advise as to whether there is some involvement of the ligament in the foot that is at risk, then you can use the MVI or the musculovascular imaging. So heel pain could also be caused by other things like tarsal tunnel, calcaneal fracture. So those are other possibilities that can cause all these areas in the plantar foot. Okay, so this ends my lecture, and I would like to end it by saying that happiness is fit in a bowl of warm, soapy water after a long walk. So thank you very much for your attention, and let me know if you have any question. If you have any additional information that you would like to share, let me know. Or you might be sleeping already because it's already 9 o'clock. Tulog na kayo.
Thank you, Dr. Jim. I just want to thank you for this very intense and good lecture. It's very comprehensive as well, but it just shows that you only know what you know. So every time I listen to your lectures, it just points
Yeah, you
out to
know
me
what you
what
know.
I know. So thank you very much, Dr. Jim, for sharing
Yeah,
this
thank you
beautiful lecture.
also. Thank you to all of you. Thank you to Jojo, Byron, mga ano to, loyalist, Paulo, and Rudy. Okay, appreciate you for your time. Kahit na si Jojo, I'm sure tulog na yan.
Thank you, Dr. Jim.
Ano, Jo?
Excellent lecture, Dr. Jim. Very detailed. To the microscopic level, Dr. Jim.
Microscopic level.
Thank
Wala
you.
nang ma-lecture, Jo, kaya yun na lang.
Oh, makikita ba yan sa ano, Doc? Sa
Exam.
Lumify?
Doc
Kitang-kita
G,
si
good
Jo sa
evening.
Lumify. Yes, yes. How
Yes, sir.
far?
Sir, question. Yes, sir. Question, sir. Sir, thank you for the lecture. Sir, question ko lang for the plantar fasciitis. Yung iba kasi meron calcaneal heel spur, di ba?
Yeah.
So would that also be a cause of plantar fasciitis?
Yeah, of course. Although, I
Ano
would
sir
say,
makikita sa ultrasound nun?
you can
Hyperemia?
also see the spur of the bones. There's a prominent echogenic
Echogenic.
area in that calcaneal part. Makikita mo siya very prominent na parang matulis na structure at the edge of the calcaneus, which means that there is
Spur.
a spur. Or you can also see the posterior acoustic shadowing. Pag may buto kasi sa ilalim niyan, dark na. So ibig sabihin, there is already an ongoing spur formation at the edge.